excited about today's session. We're going to be talking about addiction and the care of pregnant women. Our speaker is Dr. Jim Walsh. He comes to us from the Swedish system over in Seattle, and he is family medicine trained and did fellowships in both obstetrics and addiction medicine. And he's currently the director of Swedish Addiction Services. So, welcome, Dr. Walsh.
Thank you. So the hardest part, every good thing that's going to happen for pregnant moms with substance use problems is going to begin with conversation, getting started talking about it. But that's often the hardest part. It's scary often for us when we confront this problem, what to say and how to engage, but it's definitely more scary for the mom. It's important to remember that pregnant women coming for prenatal care are to some extent overcoming an enormous hurdle. If you can picture yourself in this situation, how terrifying it would be to have to confront a prenatal doctor or a nurse who's going to ask you about your substance use situation. And then you have this option to be honest or not to be honest. It takes a lot of courage for people to overcome that. People still come though, overcoming that fear because they're so anxious to get the prenatal care. So people really want prenatal care despite their fear. And when you see someone who shows up at 27 or 28 or 30 weeks for first visit, it's important to keep in mind the context of what's been happening beforehand. We usually see our moms are really hoping they're going to quit before they meet you. And they've been trying to quit, but that's not how quitting actually works. Getting it out in the open, having conversations is helpful. What really helps in the visit is the mom really wants to hear that the baby's okay, that the baby's going to be all right. And that raises the question that you have to wrestle with, is the baby actually okay? So let's talk about that for a second, just to put some context on things. When people think about drugs in pregnancy, the framework that we kind of bring with us is fetal alcohol syndrome. Fetal alcohol syndrome discovered in 1973, not so long ago, as a direct teratogenic insult to pregnancy caused by alcohol. And if alcohol is bad, it seems reasonable that other drugs must be much worse than alcohol. They're illegal, or people do terrible things to get them, but that's probably not actually true. If we think about what can happen from substances in pregnancy, you only have three kinds of bad things that can happen. You can have a real teratogenic situation, you can have placental issues, which we think about, but the patients aren't really thinking about, and then you can have developmental or brain concerns. So in terms of teratogenicity, we know that alcohol does that, that's really clear, but other substances probably don't do that. Alcohol is a direct cytotoxic substance that kills cells. Other things don't do that. They work on neurotransmitters, but they don't kill cells directly. You hear stories all the time. I've heard stories about a mom who's used a substance who had a birth defect, and people tend to make a causal relationship. But you know, of course, you need broad statistical samples to make real conclusions about this. And there's not much data like that. It's mostly anecdotal. But at least one person gathered 3,000 moms used cocaine in the first trimester, and they found the incidence of birth defects wasn't really different than they were for other matched populations. There's really no compelling evidence that opiates, cocaine, methamphetamine, outside of alcohol, those drugs are teratogenic, which is something moms are terrified about. Placental insufficiency, though, is a real thing. And it's mostly related to the stimulant drugs. So cocaine, methamphetamine, and interestingly, cigarettes. Probably more from the carbon dioxide than from the nicotine, but from both of those things, lead to serious problems in pregnancy, really on the baby growth side. Now, placental insufficiency is really not a problem of early pregnancy. I always try to remember when the baby's a little tiny, the placenta relatively is large. But as the pregnancy gets down to the third trimester, the baby gets bigger and bigger, the placenta does not get bigger and bigger, and it's harder for the baby to get all the nutrition that it needs. So cocaine and methamphetamine and cigarettes do lead to problems in pregnancy on the growth side. On average, now unfortunately most of this research is done with cocaine. We're going to have to extrapolate to methamphetamine, more commonly used drug these days, but they're similar enough that probably things are true equally. For moms who use cocaine up to the very end of the pregnancy, babies are smaller, statistically significantly so, but not as much as you'd think. On average, for moms who use cocaine all the way to the end, the baby is about a pound smaller, about 0.5 kilograms smaller, and still within the normal range. So a lot of people have had this experience of having a normally sized baby despite their ongoing use. But things that are relatively rare are more common for folks using stimulants. This is a very strange study. They're trying to separate out people who use cocaine from people who use cigarettes, which is really tough because almost everybody who uses cocaine also uses cigarettes. But in some hospital back east, they did a drug test and a nicotine test on every mom who delivered, and they found thousands of people who use cigarettes but not cocaine, and lots of people who use both, and a very small number of people who use cocaine but not cigarettes. But anyway, from this population, they concluded that these kinds of outcomes compared to normal are 4 times more common, 5 times more common for people using cocaine significantly in pregnancy. Interestingly, cigarette users in this study were twice as common as people who weren't smokers. There was one other study that compared 300 cigarette users to 300 cocaine users, and they actually found the incidences were the same. And I think it's really interesting to us because we come with a lot of assumptions and feelings about people who use cocaine and methamphetamine in pregnancy, and surprisingly not that much feeling or assumption about people who use nicotine in pregnancy, right? Although the kinds of harms are actually relatively comparable. Now, brain problems or developmental problems are much more hard to put your finger on. You can't just weigh the child at birth and come to a conclusion. And it's much harder to know. The brain is a complicated organism. When people are using a drug in pregnancy, it's definitely, when it gets in your brain, it gets through the placenta. I always remember the brain is designed to keep things out, and the placenta is designed to let things through. So substances that people are using that affect their brain are definitely shared with the baby. But that's also true of Tylenol and Benadryl and fluoxetine. It's true of lots of things. The substances do trigger neurotransmitters in the brain, and the brain's growing, and we would expect it to affect brain growth, and there are signs of brain growth changes, but it's still pretty confusing. When I think about the effect of opiates in pregnancy, I remember this little picture. This is an opiate receptor knockout mouse. It's a mouse that's been genetically engineered not to have mu endorphin receptors. And what's weird about it is it looks and acts pretty much like a normal mouse. You would expect it to be profoundly different the way we think about opiates. I couldn't find a photo because they look normal, but these mice have sex a little bit less than regular mice, but they still have sex, and they're otherwise relatively normal. It's hard to find much of a difference in them. The brain is a really complicated organism with compensatory mechanisms. It's very hard to know. But statistically speaking, there's been an enormous amount of study in this regard, and the studies are hard, and they're hard to make sense out of. If you look at global scores, like a Bailey score or an IQ score, you usually cannot see an impact of substances other than alcohol in pregnancy if you use some kind of appropriate comparison groups. So I like to think if we took moms who use a drug in pregnancy and compared them to the children of college professors, they wouldn't seem as smart. And if you compare them to people on average, they don't seem as smart. But if you compare them to other people who are poor, people with mental health problems, people who have other sort of disadvantages, it starts to disappear. And it gets harder and harder to see these differences. There's a really interesting study from Israel where they found the incidence of developmental problems for having a mother who used heroin wasn't really different than having a father that used heroin. And in the father's case, it wasn't so much around some impact of his sperm. It was around having a parent with an active substance use problem affect your development. What's really interesting and not thought about a lot is that all the studies show that growing up in a household with people with active substance use has a profound impact on development. And that kind of makes sense, but it's typically not what we think about. When we think about drug addiction and pregnancy, we think about perinatal exposure. That's where our energy is. And we forget that the real powerful developmental impacts are going to be around the home the child has lived in. Kids that have safe, healthy, sober parents do phenomenally better than kids that don't have that. That's really important. And if we approach it this way, our intention is going to be a little bit different. When I think about the care I do with a pregnant mom with a substance use problem, I have a goal of avoiding a preterm labor, avoiding a premature baby. That's mostly around stabilizing the mom and avoiding stimulant use in the third trimester. But if I want to have good developmental outcomes, I want to bring this baby towards a family where they can have a healthy, safe, sober home. And for our purposes, that's supporting the mother to transform her life so she can be sober as she raises her child. And it's a really exciting opportunity because when people are pregnant, by definition, the pregnancy is a mental leap into the future. The moment you find out you're pregnant, you're thinking about the future right away. And your using life isn't really compatible with that parenting life. So there's a cognitive dissonance that people face right away. People want to change. And there's increased opportunities for change. So there's resources for treatment for pregnant people, including the place that I work, that are not available to people who are pregnant, that are people who are parenting. There's a lot of opportunity in this moment. So to me, this is a very exciting and thrilling time to find somebody in a situation because life is going to transform and hopefully in a beautiful way. Now, you guys probably have a system for screening. You don't really need me to try to do screening, but I'd like to talk about this 4 Ps thing because it kind of speaks a little bit about how to engage in a conversation. So when you think about asking a woman about her substance use problem, she's afraid to tell you. That's normal. That's how she should feel because it's scary and there's consequences. The 4Ps kind of screening starts from the outside with questions that feel relatively safe and then kind of slowly wanders in. So if you ask about smoking first, most people with a substance use problem also smoke cigarettes. It's also good, it's a good screen in its own right. But the way you respond to a yes answer about smoking is going to let the patient know if you're a safe person to give more information to. So while you're assessing the patient, she is assessing you and deciding if you're a person I can trust with this really scary information. From smoking, they ask about your parents. I don't know about you, but I love to say about my parents. So if they've had issues, I can share that and that follows in a genetic history really nicely. From there, we get to partners. Some patients will be very protective of their partners, but it can feel a little bit safer than my own situation. Telling about you things I did before I was pregnant probably is going to be safer than things I did while I'm pregnant. And if I've had honesty about all of that, if I admitted to you I was taking pills or heroin before I was pregnant, it's kind of a small leap of faith at that point to talk about what's happening with the pregnancy. Kind of traveling from outside in is a nice way to organize a conversation like this. But what's really interesting for the most part is, because people have a natural, honest instinct, for the majority of people, if you just straight up ask them, shockingly they'll just straight up tell you, which is kind of funny. They may not tell you though if you don't ask them. And sometimes people who did lie the first time may tell you on the third time they meet you if they get to know you a little better. So Jackson Humes was better. Okay, so the scary part of asking for us is if they say, yes, oh my God, what the hell do I do now? And that's really a struggle, right? So some of this depends on where you are. So at your clinic where you work, you may have a doc who's really interested in this topic, you may have a social worker with some expertise, and you're able to put them in front of that person. You may be the only person, it may be just you, okay? There are usually through health departments, and I apologize for not knowing about what happens here exactly, there's usually specialty nurses that work with high-risk pregnancy. I've heard nurse-family partnership is what it's called here. You've heard Moms Plus in other places. There is usually long-term case management support services that are really powerful. I did confirm that the PCAP, Parent Child Assistance Program, is run through Triumph Treatment Services here. That's like a 2-year case management thing, a really powerful program. There's probably lots of other services like that too. There's regular outpatient treatment. That's when we think of treatment. People sit in a group and talk together. Usually that's pretty intensive. They call it IOP, 3 hours a day, 3 days a week. It's a pretty significant time commitment. A lot of people struggle with that. Some places have services like that designed for pregnant or parenting women. That's really awesome if you have them. There's rehab, 28-day inpatient rehab like Betty Ford. That's kind of what I do at Swedish Hospital. We do an inpatient rehab program. We do it at the hospital just in case they go into labor or something. But it's basically all the things you think about from going to a rehab program. That's the service we offer. And then there's residential long-term treatment. There's 6-month treatment designed to focus on the recovery and the parenting at the same time. And you guys are like the hot place in the state right now. Triumph's got more beds than anybody else, and in fact, the only place you can probably get in these days. And they have a pretty good reputation, so you're really lucky to have that here. Although honestly, there are occasionally advantages to go further away for your treatment, because there may be people close to you that call you back into that world, and there's programs in Spokane, and programs in Everett, Washington, and occasionally it may be better served for them to go elsewhere than stay close to home. And very, very importantly, there's opiate maintenance treatment with Methadone. So let's talk about opiates. So opiate use in pregnancy, really specifically heroin use in pregnancy, is associated with a lot of bad pregnancy outcomes, which is kind of funny. Because when we prescribe opiates to people, we don't really think a whole lot about it. But it probably makes sense, because most of the outcomes are probably not caused by the opiates directly. They're probably caused by the context that we use. Poverty, things people do to get it, just the context of care, injecting if you're injecting, but also the withdrawal. And the withdrawal may be a significant impact both immediately and chronically. So in general, we know that opiates don't cause birth defects, so there's been one of those weird articles on that retrospective data that came out a few years ago. But for the most part, there's confidence that opiates are safe in pregnancy. But opiate dependence, the physical dependence, does develop in mother and in baby as well, and the opiate withdrawal is unpleasant. So if you've seen people in opiate withdrawal, they really, really need it. The very nice people who normally would do bad things will rob from their grandma to avoid opiate withdrawal. Opiate's really good. I've seen like a firefighter who run into a burning building to save a kitten, like brought to tears by his fear around his opiate withdrawal. Opiate withdrawal is really bad. It's one of the worst things that people experience. When you see people in really bad withdrawal, you can tell, although even a little bit of withdrawal is pretty unpleasant. The pregnancy also goes through withdrawal, and you can see that. If a mom's regularly and restless, with ultrasound, you can see the baby get regularly and restless. And you can get bradycardia in opiate withdrawal, and we can also see fetal bradycardia. So here's kind of a story, an anecdote. So there's a mom who was taking opiate pills. This is back when pills are more common. She was taking them somewhere in the eastern side of the state, and she thought she would take what they called a geographic clear. She'd moved to western Washington, where she didn't know anybody. So she moved to Western Washington, she took her last few pills, and she was driving somewhat erratically, and the cops pulled her over and they took her to the police station in Mentor. And she stayed there, as happens when you go to the police station, for a long time. She was there like 18, 20 hours. And the pills were off and she went into opiate withdrawal. She was about 27, 28 weeks pregnant at the time. When she had opiate withdrawal, she didn't say I had opiate withdrawal, she said I had cramping. But opiate withdrawal causes cramping. They took her to the local hospital there, and when they put the baby on the monitor, they saw fetal decelerations. So they did an emergency C-section. And that's not a rare story to hear that opiate withdrawal triggers signs of fetal distress and signs of early labor. So we try to avoid opiate withdrawal for pregnant people, and that really is where methadone fits in. And we're going to talk about buprenorphine as well, but I'm going to start with methadone because that's the old school, and most of the research has been done in this regard. So if you take people who've been using heroin and put on methadone in pregnancy, you see a lot of profound improvements. Pregnancy-wise specifically, you see people getting their prenatal care, you see baby growing normally, you see less fetal death, that's a good thing. And something that's usually not measured, but is one of my favorite things, more likely that the mother's going to be able to be the parent to her child. Interestingly, studies show that if the doses are higher, the babies are more normal, by which I mean birth weights. And if moms start early in pregnancy, the babies are more normal. And basically for moms who are on methadone in first trimester or before they got pregnant, obstetrically speaking, you don't find any problems whatsoever. They basically have babies that have normal birth weights and normal courses of pregnancy. Higher doses are better in this context, probably because higher doses are associated with less likelihood of using. And in the methadone treatment world, we know that the effective dose for most people is around 100 milligrams a day. And when you see people at lower doses, often they're not staying sober. So higher doses are generally better. Methadone treatment leads to improved outcomes, but people still struggle with them. Healthcare providers, nurses, and doctors struggle with accepting it sometimes, and patients struggle with it a lot. They feel like they're doing something wrong. They feel bad about it. They wish they didn't have to do it. And one of our jobs is to help people feel good about it. Feel like they're doing something positive for themselves, for their pregnancy and their baby. When you have an addiction problem, the frontal lobes of your brain tell you that I can just decide to quit. It feels like I can just quit. It feels like I can quit tomorrow. Today, maybe not today, but it feels like I can quit tomorrow. I think that's the same way I'm going to lose weight. I'm definitely going to lose weight tomorrow. But today I'm going to have a donut. Because the part that wants a donut is not up here in my frontal lobes where I think in words. It's down there at the bottom of your brain, the little reptile brain. The amygdala, the nucleus accumbens. Some of those little parts down below, just like a lizard, wants its donut today, right? But my brain is telling me I'm not going to have it. And this is a continuing problem for people. They have trouble understanding and accepting that willpower is not the way people get sober. And what you can do that's incredibly helpful, so powerful for every healthcare provider, is help the person to feel like the methadone is part of their healthy pregnancy. Okay? So when I do an ultrasound and I see normal fetal growth from all methadone, I say, you should be so proud of yourself. You're doing what you need to do. Or doing your medicine is a part of that. So good for you. It's not just the mom that needs to do it though, it's her partner. So she can be understanding it's what she needs. She's learned from bitter experience that trying to quote unquote just quit doesn't work. But her partner's like, why are you doing that to the baby? You gotta get off that stuff. When are you gonna get off that stuff? If you say something positive with methadone in front of the partner, it's a good wake-up call. But it's not just the partner, it's her parents. And then the worst people of all, your partner's parents, right? The most judgmental people in the universe, right? So it's really meaningful. If you have the ability and opportunity, particularly if you're prenatal care providers or delivery providers, if the patient's comfortable with disclosure, speak about the medicine in a positive way as part of the healthy pregnancy parent story in front of these family members will really transform things and take the heat off her and help her stay on track. Why not just detox though? Wouldn't detox be better? Like, could you detox? Is it safe to detox? Well, we talked for a long time it probably wasn't safe to detox. And we say that because we see people who just kind of quit and bad things happen. People who just stop taking their methadone, get a lot of miscarriages, become labor. People who just go too bad with heroin, bad things happen. But there has been some research, usually done by MFM doctors, usually in the South, where they bring people in the hospital and they wean them down over about 2 weeks or so with methadone. And it's not as dangerous as people had assumed it would be. So you probably can. Now, some bad things do happen. There are some preterm deliveries, there's some miscarriages, but they say that they're no different than the normal percentage. I'll assume that's true. So all the baby comes to read that. Some of them don't do a lot of observational monitoring. Some of the data is not reported very well. So it's a little unclear. But maybe theoretically, in a very controlled setting, you could wean people down over 2 weeks. But you shouldn't do it anyway. It's a stupid thing to do. Because relapse is the predictable outcome of this effort. And even people who go through a great effort and come through safely, the majority are going to relapse. So this is the first study like this. I was done in London, actually, when 101 patients started the program. Now, then they look to see who they deliver. They can only track down 24 women at the time of delivery. I don't know how the other 75, maybe they delivered someone else, maybe they were fine. But of the 24 they could track down, only 10 actually had managed to finish the detox. None of them had done follow-up care that they could tell. Only one wasn't actively, 1 out of 24 was not actively using the time of delivery. The average birth rate was 5'10", which is not catastrophic, but it's kind of low. It didn't really pan out because people didn't really stay sober. Only one study, the whole purpose of this detox is to avoid the NAS. We'll talk about NAS a little bit. Only one study actually showed a decrease in NAS. That was in another country where everyone was in a long-term residential treatment program. Interestingly, in my experience, the patients who really want to come off methadone or buprenorphine are not the people volunteering for long-term residential care. Quite the opposite. They're people who want the addiction problem to go away. And this is because having an addiction problem is a mark that you're a bad person, right? And that's how people feel, right? Now, this is not so unusual in medicine. Most of you guys here are old enough to remember when if you start on the antidepressant, as soon as your depression got better, you're like, when do I get off the antidepressant? And some of us are old enough to remember way back, people get on hypertensive medicines. And this is their blood pressure got better. They're like, when do I get off hypertensive medicine? Right? There's been an evolution that having a disorder doesn't mark you as a failure in some sense. Opiate use disorder has not quite caught up to that yet. It's probably the most stigmatized health condition that we have so far. And I always draw a parallel within diabetes. If somebody had type 2 diabetes and they lost 100 pounds and started jogging 10 miles every day, they probably wouldn't need medicine. Right? And there are people who do that, but there's not very many people who do that. For most people, they need medicine. They may do a little bit of both. They may, give up sweets and take metformin, and we should be really happy with that, right? For people with an addiction problem, if they change all their friends and go to a 12-step meeting every single day and really work hard in their spiritual life, there are people who can stay sober, but it's probably only about 10%. With opiate use disorder, it's a pretty small percentage. So medication combined with all the other things to whatever degree is possible is the way to have success. Okay, that's not important, so you're ready to talk about that. The ACOG has been 100% on board with this for those people who are obstetric folks. They're very clear that detox is not the right treatment, that maintenance treatment, methadone or buprenorphine is the right way to go. So if we put people on methadone, the babies are healthier, we should feel great about that, but then there's this thing about the NAS, the neonate abstinence, and that feels really, really bad. The NAS seems like a disaster. I try very hard to reassure moms that NAS is a manageable, treatable, predictable health problem, that it's a thing, but it's not a disastrous thing. Now, one way we could lower NAS is to use buprenorphine instead of methadone. So buprenorphine is another way of doing opiate treatment. It's some ways better, although some ways not as good. Buprenorphine is a funny molecule. It binds the endorphin receptor, that endorphin receptor, just like any other opiate, but it binds there and has a dual effect. It has an opiate effect and an opiate blocking effect at the same time. It has a double nature. And that really transforms how it affects people. From a sobriety perspective, it's a great medicine because you can have a relatively small amount of opiate effect and a high degree of opiate blockade. So if you're on buprenorphine, Suboxone, or Subutex, if you try to use heroin, you pretty much don't feel it. Methadone can do that too. Methadone does do that, but you need a significantly higher amount of opiate effect to get there. So buprenorphine is a really effective blocker. And the really cool thing too is if you take extra buprenorphine, nothing extra happens. So you can't misuse your buprenorphine, and if you take it, you won't use heroin. So that's really awesome. For those who haven't dealt with this, if you want to be a prescriber of buprenorphine, there's a weird rule the government made that you have to take a special training class and you have to register with the DEA, which kind of creates a real barrier for people. It's an unfortunate rule, but that is how it is. So if you want it, then you gotta go through the hoops. For people who take buprenorphine in pregnancy, the obstetrical outcomes are as good as methadone. Some studies actually show a little bit better. That's probably selection bias. In a lot of communities, poorer or more chaotic people get methadone, and richer and more functional people get buprenorphine. And so you do see some bias, but for the most part, they both become babies. But you do definitely get less NAS. And there was a wonderful, really well-designed, randomized controlled, double-blind trial that really showed this. And they showed that for moms on buprenorphine, the amount of morphine the babies need was phenomenally less. The length of stay in the hospital was better. Although interestingly in this study, the incidence of babies that needed medicine wasn't that much different. So we'll cross that bridge a little bit later. But buprenorphine is better. In most settings, moms on methadone, about 90% of the kids are going to need medicine. When in research settings, it's more like 70%, so that's the kind of thing. And in most places, moms on methadone babies stay on average about 3 weeks. A lot of variation between institutions and even between families. In most places, buprenorphine, about half the babies end up needing medicine, so it's less. And when they need medicine, it's usually about a week and a half, not 3 weeks, so it's significantly better. Now, we do tell our moms on buprenorphine to expect the baby's going to stay, because if they don't expect that, it can be devastating when the baby stays. And you know, if you're a person with an addiction problem, the worst thing that could happen is that your addiction problem hurts someone that you love. That's something people live with. And for a mom with a baby, that's kind of that knife's edge they kind of live on. So for a lot of them, the sense the baby needing medicine is a sign that I'm a failure as a mother, that I'm a terrible person. So we try well before this to normalize it, to expect it, and to make it like it's a manageable thing and focus on the stuff that they can help. In terms of choosing methadone or buprenorphine for patients, there's a lot of reasons to choose either one. For NAS, buprenorphine is definitely better, there's no question about it. And for the patient, being on buprenorphine is a hell of a lot easier to do. And methadone, you got to go to the methadone clinic every day to take a controlled dose. Buprenorphine, you get to see your regular doctor in the regular doctor's office and get a prescription. That's so much better. But there are situations where methadone is better. In that randomized controlled trial, the dropout rate for buprenorphine was twice as high as the dropout rate for methadone. That's because for some people, the buprenorphine just isn't strong enough, and they still have ongoing withdrawal. If you stick with it, your body will get used to it, but it can take like many weeks for that to happen, and some people can't get their sobriety to methadone. So methadone's better for some people. Also, the structure of the methadone clinic is better for lots of people. So if you go to clinic every day, you have to like look at that nurse every day. Just, how are you doing? You know, and that's like a powerful intervention, right? But more importantly, you don't have your medicine with you. So one of the problems of buprenorphine prescribing is that if you take extra, nothing extra happens. So you're not going to misuse it, but you have friends, right? And in the using world, sharing with a friend is a normative behavior. I like to think, you know, if you're a smoker, you can walk up to a complete stranger with a cigarette and ask for a cigarette, and that stranger will give you a cigarette, which is not cheap, right? If you walk up to them with a sandwich and ask for a bite, they won't give you a bite. Sharing is expected. In the opiate using world, where opiate withdrawal is known to be so horrible, you're supposed to share. Not sharing is weird and is considered wrong. But if you're the prescriber of medicine, that's not good, cool for you. And if someone, an old friend calls them and they give some of their buprenorphine to their friend, what's going to happen is they're going to run out. And when they run out, they'll call the same friend back, but friends are going to have buprenorphine, they're going to have heroin again. So sharing with friends is really where we really struggle with this the most. I often think the predictor of success with buprenorphine isn't anything about the patient, it's about who they hang out with. You know? So there's things you can do about that. Now, if you go to Triad Treatment Services, that's not going to be a problem because you're in a controlled setting. We sometimes use moms to help if you're a youngish sort of person, and the sharing is a much bigger problem for younger patients than for older patients. 38-year-olds don't care about family anymore, but 21-year-olds care about their friends. Right? So we often use mom to help out. We bring mom into the office, say, Mom, here's your deal. You don't have to worry about Sally taking it, but you want to make sure she's give it to a friend. Can you hold it and give it to her every day? Usually the patient is grateful for that, because then when their friends come ask for it, they can be like, Mom's got it, I can't help you. And it gives them some relief. So usually that works out really, really well. And most patients will see 50% of grace. But some of them don't have a mom like that. Sometimes your mom is using it, right? Can you imagine saying no to your mom when she's in opioid withdrawal? You're not going to manage that. I had one patient was sharing with a twin sister. What could you do? How can you turn your twin sister down? So for some patients, the structure of the methadone clinic pays off. Some methadone clinics actually offer daily observed buprenorphine treatment specifically for this situation. I don't know if that's the situation. So let's shift from there and talk about patients who are on buprenorphine, patients who are on methadone, what you're going to do for them through the course of their care. So prenatal care is pretty easy. It's the same as the regular prenatal care, right? So if you're on methadone, you don't have to think about it. The methadone clinic handles that. But there are dose changes that normally occur through pregnancy, and it's helpful for you to be aware of that, and it's helpful for you to support the patient in that. So if you're on methadone before you get pregnant, there's an increase in total body water in early pregnancy, meds get diluted, and usually doses have to go up about 10% in early pregnancy. Much more commonly, people got started later, so it's not a big deal. But in the beginning of the third trimester, between 25 and 29 weeks, there's an increase of hepatic metabolism, and methadone doses usually go up about 15% around that window. Everybody's different, but usually by 30 or 32 weeks it stabilizes. It doesn't keep going up the whole time. So doses are expected to go up. Patients feel weird about asking for dose increase though, sometimes they're afraid to ask, and some people relapse because they start to feel withdrawal in that moment, which that's a mess. So if you're providing prenatal care, just checking on the patient and letting them know it's okay to tell the clinic if your dose isn't right, that your dose probably needs some adjustments. Interestingly, if people's doses are just right at the end of pregnancy, it's often then too much a couple weeks after the babies are born because their metabolism slows and they get kind of drowsy and naughty. Clinics know that too, but they still kind of wait for the patient to say something. If you see a patient with postpartum universe who's had to staying awake, just reminding her to check in with the clinic and make an adjustment is a good idea. With buprenorphine, that's a little bit less clear. There's clearly the same pharmacokinetic changes happening, but buprenorphine seems to be less dose sensitive than methadone, particularly as you get to the high dose ranges. So if you're at 16 or 24 milligrams a day, it may not matter that much if your dose is exactly right. The buprenorphine has a little more flexibility in that regard. But we do see some people have dose increases at that same time. So should you be worried about the pregnancy safety, or should there special things you should do? Should you do NSTs? Nobody knows. There's no real data about this whatsoever. Someone did a great study where they asked places where they do a lot of addiction and pregnancy together, what do you do? How much monitoring do you do? And there are some places where they do twice weekly NSTs in the last week between pregnancy, and some places don't do that at all. A broad range, and there's no right answer. What we do at our place is a single growth ultrasound at 32 weeks, around 32 weeks. And then we only do monitoring that's indicated for that purposes if they have IUGR, if there's any other obstetric indication. But no one really knows the right answer. I find in general that doing ultrasounds seems to be really helpful therapeutically. Moms see the baby, they feel very connected, and it seems like a joyful and inspiring moment. For reasons I don't understand, doing NSTs are not experienced like that. They're experienced annoying and almost judgmental in some sense. People feel judged in the context of checking out the baby by NST. I'm not sure why that is. Maybe we're doing it wrong. But if I have my choice with ultrasound and NST, I'll always do an ultrasound. The people who do the ultrasounds, who pay for them, don't always agree with me in that regard. But I find it helpful. But the other thing I think during the prenatal care is getting the family members in and letting the family members know that this can be a healthy baby and that the medicine's not a bad thing is really valuable. So I encourage you to do that as much as you can. If they're in labor, again, do what you normally do. Don't worry about it. Throw on methadone, continue their methadone. Throw on buprenorphine, continue their buprenorphine. If they're on methadone, though, you are supposed to call and confirm with the methadone clinic. And this is smart, because methadone's powerful medicine. And if you made a mistake, if you gave 130 when it was really 30, and those are both reasonable methadone doses, the patient could overdose and die. That would happen. So you're supposed to call and confirm with the clinic. Methadone clinics can be hard to call sometimes. They're very sensitive about releasing information. Normally they won't tell you anything without a signed release, but they will tell you just this dosing thing at the hospital. They'll tell you that. Methadone clinics open up very early, and by 1 o'clock, they're mostly gone home already. So if we're going to call the clinic, I try to get the night shift to call before they go off shift. 6 o'clock in the morning is a great time to call methadone clinic. Even by 11, it's getting kind of late at the methadone clinic. So we try to call really, really early. For buprenorphine, you can probably continue it. Patients know their dose, and buprenorphine is a lot safer. Although it's awesome if you're not the buprenorphine prescriber to let them know that they're on the baby. It's pretty cool. So for pain management, where it's interesting, important to remember that the methadone or buprenorphine doesn't do anything to help their pain. Sometimes people think, why should she be in pain? She's on 150 milligrams of methadone. That's thinking wrong. Doesn't help their pain whatsoever. You can give extra opiates, and they help, but they don't help very much. So if you give additional opiate medications, you should be expecting a greatly diminished impact. If it's really important, you may give a lot. I find in labor, I'm going to head towards the epidural if there's pain. And anything else is just stalling until I get the epidural, at least in my center. So I know some places give fentanyl or dose of morphine, just till like the anesthesiologist gets there. That's fine, you can do that. I don't give extra in this context because I don't care that much. And I may be embarrassed because I'm a man, I shouldn't talk about these things. But I don't worry that much about it because I know we're going to head towards the epidural. But you can do that. For people on buprenorphine, theoretically, higher affinity opiates will work better than low affinity opiates because you're kind of fighting for this high affinity receptor. So fentanyl or dilaudid might work better. Now, I've never worked at a place where they give Fetal or Butane for pain relief, but that is done in some places obstetrically. That would be disastrous because those things are all partial blockers and you'll precipitate opiate withdrawal. You guys use those here ever? Yes, oh my God. Don't give those, that would be a disaster. So if you give morphine or fentanyl dilaudid, it won't do much, but it won't hurt. But if you give butophonol and nalbuphine, that's going to be terrible. So please don't do that. So, but your epidural or any kind of local anesthetic is going to work fine. So if you're heading down that road, just go with it. Okay, for postpartum care, you're obviously going to continue their methadone, and there's one little trick on that. That's the point of discharge. So methadone clinics, you take the dose under observation every day, but they're closed on Sunday. right? Sundays, they rest. So what they do on Sundays, on Saturday, they give you a little bottle to take on Sunday, right? So that's cool, but this can make your life a little more complicated. You really can't discharge a patient on a Saturday, right? They're stuck. And I know obstetrical length of stays are a big deal and managed very tightly, but you just really can't discharge a patient on Saturday because they won't get their dose, and that's not a cool situation. So you can discharge them incredibly early Saturday morning at 5 a.m., and they can maybe go straight to the clinic if they're together enough to pull that off, right? That requires planning ahead. These clinics close early. One of the clinics closes at 9:30. I don't know if it's your clinic. The one that's closed, they open up at 5 on Saturday and they close at 9. Right? Imagine that. So people in methadone clinics expect to get up early. I don't know what they do here in Yakima, but you got to go really early. So typically if it's Saturday, you're stuck till Sunday. That's just how it is. You got to plan everything else. For buprenorphine, it's no big deal. I didn't really get into this, but it's traditional in pregnancy to give the plain buprenorphine, the Subutex, and for non-pregnant, it's going to give the combination buprenorphine with naloxone, Suboxone. The purpose of that combo is to dissuade people from misusing it by injecting it. Because if you inject Suboxone, you basically just get Narcan. In countries where they used only the plain buprenorphine, there was a little bit of injecting that went on, and that was embarrassing. That's why I invented the Suboxone. It's been traditional to give plain buprenorphine in pregnancy. We usually do that in our practice because all the guidelines say that. But there's actually no evidence that Suboxone is a problem. And in fact, some of the leaders in the field, including the lady who did that New England Journal trial, they actually use Suboxone in their practice now. That's relevant because you have to get prior authorization for Subutex, which is really annoying. Whereas with Suboxone, you don't need prior authorization for Medicaid patients. What we've started to do is let the patients know if you want to just take the Suboxone, that's okay with me. But everyone's read that you're supposed to take Subutex, so it freaks people out a little bit. So most of our patients are still on the plain. But I think 5 to 10 years from now, that's going to go away, and everyone's going to need Suboxone. So, okay. So postpartum pain for vaginal delivery, if you're giving pain medicine for people on methadone or buprenorphine, since opiates are blocked, other stuff may work better. NSAIDs, Tylenol, and some of an ice pack may work better than opiates. But opiates don't really cause any problems either. They're not going to cause the patient to relapse because the methadone or buprenorphine blocks most of the effect. So if you're in a place where you usually give opiates for vaginal delivery, it's okay to do so for these patients. And if you're in a place where you usually don't give opiates, that's probably better, right? So we did a big survey at Swedish. We found different practices do completely different things. And some practices always give some opiates for vaginal delivery, and some practices never give opiates. It was the midwives who were doing the better job in this regard. So, but we're trying to shift to never doing it for everybody and making institutional practice in that regard. But you can basically do whatever you usually do. Okay? But C-section where it gets exciting. Because C-section, you're going to have to do something at the level of pain like we're seeing right now. So for people on methadone, remember the methadone has to be continued, and the methadone does not help their pain, and opiates are going to work significantly less, and patients on methadone have a very high tolerance. So as we're using opiates for patients on methadone, we're going to need a lot. The patients on buprenorphine, all that stuff's basically true, but in addition to having tolerance, they've also got blockade. So the buprenorphine is blocking some of their opiate effect. This makes it very challenging to treat their pain, but it's not that hard if you think about it ahead of time. Some people have given weird advice where people are told to stop their buprenorphine before they have their baby, before their C-section. We don't recommend that at all. The worst case scenario would be a relapse going. So if we use opiates effectively, we can do well. Now, in addition to giving the right amount of pain to treat their pain, you also have patients who are scared and nervous. People are assuming their pain's not going to be adequately treated. They're afraid. And those fears are rational. That's what usually happens. Most places don't do a good job managing pain like this, and they've heard stories and they're scared. So you're trying to overcome that anxiety. And we find in general, aggressive treatment in the first hour or two will lead to a lot less pain complaint, a lot more confidence from the patient, and the whole thing goes well. And I keep my eye on this breathing story. So you're giving high doses of opiates, and I've had a provider, a pharmacist, doctor nurse say, we can't get that much, they're going to overdose. For patients who's like writhing in the bed in horrible agony. If you have a patient who's awake and alert and breathing, you have not given too much opiate medicine. So this is the money slide here. Okay? This is what you should do. Okay. So now I use hydromorphone dilaudid just to make my life easier. I'm not saying it's better than anything else, but I wanted to learn just one set of numbers. You could convert this into something else and work just as well. My favorite way of treating the pain, yeah.
Do you use epidural narcotics?
Absolutely. We're going to come to epidural, but yeah, and that's a great
that
idea.
would avoid some of this.
I think so, absolutely. I think you're 100% correct. So that's going to come later. Start with that. So that's so smart though. So I use the letter. I prefer to use it by PCA, and a PCA is almost always a better choice because you don't know how much the patient needs. right? And if you write a PRN opiate medicine, what you're insisting is that every X number of hours, the patient and the nurse are going to become enemies for a little bit, right? And it's stressful, and it's unpleasant, and this sense of being judged lingers very heavily over PRN opiate medicines. It's really toxic, and it's not doing anyone a favor. So PCA, if you can get it, is phenomenally better. So, but on the other hand, the PCA doses should be higher. So in our institution, the normal PCA dose per button push starts out at 0.2 milligrams, which you can get every 8 minutes, which is bad. And the nurses are allowed in our institution to escalate up to 0.6. But that's still usually not enough, so we give more. I usually just multiply every times 3. We find 2 to 5 times the normal dose of where you want to go. We've had sometimes 1 to 2 milligrams. That's starting out at 5 times normal per button push. Sometimes I'll start out at 0.4 or 0.6 per button push, but you want to really increase what the patient gets. I don't use a maximum, because the whole point of the PCA is you can't overdose yourself because you get sleepy. It might be dangerous if your boyfriend was pushing the button for you, but I've never seen that happen. I hope that wouldn't happen, so that's a concern. So you can do a nurse bolus, but the whole point of the PCA is the nurses shouldn't have to bolus the patient. So if the nurses begin to bolus more than once or twice, you're doing it wrong, and you should just raise the dose to what's enough. Patients will sometimes take an enormous amount of medicine. If you look at the numbers, it's a little bit scary. If you look at the patient, they look perfectly fine. It's pretty much impossible to opiate overdose a patient who's on methadone or buprenorphine, as long as you don't give them benzodiazepines. Don't give them benzodiazepines. Now, there is a pressure not to use IV medicines, though. Apparently, since the hurricane in Puerto Rico, we're running out of IV medicines. So can you do withdrawal medicines? Probably yes, but you still need a lot, and you need to get a jump on things. So we've started to do at our little hospital, where there's a small number of providers and everyone knows each other really well, we've started using an oral regimen. It's working pretty well. And we do something really weird. We have scheduled, because we want to do scheduled medicine, scheduled dilaudid. Now the normal oral dose is 2, so we multiply times 3 to get 6, right? But we have additional PRN dilaudid. Why do we do that? Because maybe the scheduled dose isn't right, right? But I tell the nurse, if the patient's taking the PRN medicine more than 2 or 3 times, then we should raise the scheduled medicine. And by the second day, they're only on scheduled medicine for sure. Now, for patients who are on methadone or buprenorphine, all these opiates, even these very high doses, don't really work as well as they should, and you're probably going to get more pain relief, honestly, from all the other stuff. So doing all the other stuff is really important. So NSAIDs help phenomenally for pain. They really work a lot, but people forget to take them. And if you order them PRN, you'll have a nurse and patient fighting enormously over 5 or 10 milligrams of oxycodone who never took their ibuprofen. So if there's no contraindication, please order the NSAIDs. And don't order PRN, always order it scheduled. Always order it scheduled, so take them. Now there are contraindications. Bleeding and uterine tone being an issue. There's been a lot of controversy in the MFM world about gestational hypertension and when is it okay, when is it not okay. There's been some shifts. So you have to decide if it's obstetrically safe, but if you can give it, please give it. Often we start with Toradol for a dose or 2 and then switch over to scheduled ibuprofen. I'll leave that to your discretion. Acetaminophen helps a lot too, and people forget to take it. If it's PRN, no one's ever going to remember it. So put it on the schedule, and the combination of those two is amazingly effective. It's put it really well. Duromorph, I think, helps enormously. I was surprised how well it works because I think of buprenorphine as blocking morphine, but the concentration of morphine with fecal or epidural morphine is just incredibly high, probably enough to displace it. So I think those work well. And there are some institutions where they don't normally use opiates for C-section. They just do all these other things, and they work really well. And I think you can get great pain relief. But if other patients get opiates, our patients get opiates. Then there's other cool things as well. So some places leave the epidural in longer. I've seen that happen. You have to get the anesthesiologist to be cool with that. It's more working anesthesiologist. Some people do these tap blocks, locally infiltrated. Dr. Moran told me he did one not so long ago, so that's pretty cool. I don't know how to do them myself. Back in the big city, only anesthesiologists get the cool stuff like that. But maybe your team could do that. And I've had some people tell me they work incredibly great. Other people tell me, yeah, but it's a good idea. Gabapentin may help a little bit. There's been some studies in non-pregnant patients showing some significant help with post-operative pain. There was one study with pregnant moms where they gave the normal doses, which are 600 TID, and apparently there was a lot of sedation for the moms. So we don't want to go to high school. We give a pretty small amount. We give 200 TID. I can't really tell how much it's helping because we kind of throw the kitchen sick at them, but it seems like it helps a little bit. So main thing is to avoid benzodiazepines. Occasionally you get an agitated patient. Occasionally nurses ask them to give them, and occasionally nurses right. It cools down a little bit. But if you have benzo, the risk of respiratory suppression is a thing, and we prefer not to put down that road. Okay. So if you've done a PCA, a source of anxiety is how to get them off the PCA. So I don't think how we do it probably doesn't matter that much. So we usually stop the PCA the next morning. Whatever time it went on, I like to stop in the morning because you want to have providers around who the patient knows and trusts because they're going to be upset and worried about this. Because going from IV to PO is a little scary, right? We let the patient know it's going to go. If you walk in and just tell them you're stopping, they're going to freak out. So we tell them ahead of time it's going to stop at 9 o'clock. It's going to stop tomorrow morning. Just be aware, be apprised. We give the first dose of scheduled oral medicine before we turn the PCA off so that it's working, so there's not a little hole in the middle. So that's going to freak the patient out. So then the real question is how much? And the PCA can guide us. So what I'll do is add up how much they had in the PCA over the last window of time, and then I convert from IV to PO. If I stick with Dilaudid, that's pretty easy. It's multiplied times 4 to 5. Right? Now the number is really high. It's terrifyingly high. But I also know I'm not going to overdose these patients. On the other hand, people with C-sections get better pretty quick, so I usually drop it a whole lot from what the conversion would have been, third, half, 2/3 sometimes. And then I turn it into the scheduled Q3-hour dose and I divide it out. So, and that works out pretty well. If it's not enough, I go back and I make it higher, but once I go to oral, never go back to IV, right? Because then you'll be bouncing back and forth and that'll be a source of stress. Okay. Patients may go home with very high doses of opiates because they're taking high doses. And that can be stressful, particularly a patient with a substance use disorder. No, thank you. But they don't take it for a very long time. So our folks won't stay on opiates longer than anybody else who had a C-section. So I ask different doctors I hear, 2 weeks, 10 days, 5 days. We usually find within a week it's gone. Maybe a week after we get out of the hospital. We, on the other hand, do get a little worried if they have a ton of medicine. Maybe they'd be tempted not to go to the methadone clinic the next day. I've never actually had that happen, but it's a source of anxiety for me. So what we usually do is send people home with just 2 or 3 days worth and try to see them a little sooner than you see the average patient. So a few extra visits in between. Usually there's other emotional stresses for patients that checking in is really pretty cool. Okay. So breastfeeding is 100% double plus the right thing to do. So breastfeeding is definitely safe on methadone. They've measured the amount of methadone in the breast milk. It's a very small amount. It's a tiny fraction of what we give the baby to treat the NAS. It doesn't hurt anything to breastfeed. And in fact, breastfeeding is helpful. They show that moms who are breastfeeding, their babies have less withdrawal. It's probably not from the amount of methadone in the milk because it's not going to make a difference. It's probably just because they're held more. That's what babies are for. So breastfeeding is really good. And the same is true of buprenorphine. Buprenorphine, there's probably not much that gets through. It's a lot smaller amount. Somebody did once find some metabolites of buprenorphine in baby's urine. No one's really tried to measure baby's serum, but there's no effect that you can tell. It's not enough to make any difference, and breastfeeding is very helpful. Breastfeeding shouldn't just be allowed, though. Breastfeeding needs to be encouraged. So breastfeeding is a scary topic for people. Again, our patients sort of assume that we're judging them, and breastfeeding is a really hot place to be on this issue. Most hospitals don't do a good job even allowing people to breastfeed, let alone encouraging. People need extra support and need a lot of reinforcement. I won't read this, but this is a study with Scotland where they did some review of people describing their experience. It's really scary to feel like it's okay to breastfeed your baby. There's often a lot of judgment from partners and parents, and often the nurses can be perceived as judgmental, whether they're trying to be or not. And the normal things we do to encourage the average pregnant woman to breastfeed may not be enough for these moms. They might need extra help, specifically around the open situation. And I threw this up here to say that women have experienced, again this was in Scotland, not in Yakima, but women experience the sense that they're being judged and discouraged for breastfeeding. Sometimes I think just the normal structure of flow in the NICU makes it really hard for moms to engage with their baby, to schedule the time, the framework. But often now all that stuff is perceived as a judgment of them as a person, particularly about them as a person with a substance use disorder. So it's really good to be aware of that. I think it's a fair bit of work to bring people through breastfeeding anyway, but in this situation it's a little bit more work. But it definitely pays off. The most effective thing you can do to encourage breastfeeding, and in fact the most effective thing you can do to lower your duration of NAS, is maternal room unit, putting the mother and the baby in the same room, which sounds really easy for money reasons, for construction reasons, for facility reasons. It's sometimes not that easy. But honestly, that's a shame on us, because that's honestly something that we could do. It's within our power. So when I say the Swedish is not great about that either. Sometimes they get to room in because these beds are available, and sometimes they don't because those beds are not available. And the hospital doesn't really make it a priority for us. But we know when people do it, it pays off. Now, I'm not an expert in NAS, but I would encourage you to, if you have another hour to spare sometime, look at this video. This is a 1-hour webinar from Dr. Grossman at Yale, and they have had profound changes in this experience, mostly by changing their context of care. This is not going to be very visible here, but if you can see, this hard-to-read white line is their average length of stay. And they went from, actually started at 28 days at one point. This is sort of the outliers. But they went from 22 days down to 5.9 days average length of stay. That's really profound. It was a journey over 10 years. They did it by A, putting the mom and baby room together. B, changing the way the mother received her care. So she was understood to be the prime caregiver of the baby. They went from non-pharmacologic treatment as sort of an asterisk at the end to something they really thought about hard, focused on mother-baby care. They had breastfeeding, but they really worked hard to support breastfeeding, and they changed their medication systems, which I know you're in the process of doing now, to the new Eat, Sleep, Console. But the sense from that webinar, which is really inspiring, was it was really about bringing the mother diet and really supporting the care process. So really, really profound changes are possible. I can't say that we've solved this problem, and because of things like they're in the NICU and the nursing staff and the rooms and all this stuff, hasn't been solved, which I'm embarrassed about. But we know it's possible to do, and it's really our responsibility to make that happen. Okay? That's that. So I'll just leave it there. So thank you for listening. So I really appreciate this. You know, opioid use disorder is a really treatable disease, and the pregnancy creates a context to move forward like no other time. The patients are ready, the system is ready, everything can move forward. Often the care of pregnant people will transform the whole climate for the way people with opioid use disorder are treated. So you guys are going to be kind of the leaders of moving this forward. So I'll stop now. I'll take any questions.